With an aspiration in a quantitative neuroradiology career, that's so smart I can't even say it. Now let's welcome him as he comes up to answer the question, can artificial intelligence bring a human touch to precision medicine?
Over the past few years, many of my friends, teachers, relatives, and mentors have often asked me, Arjan, why is it that you're constantly poring over these spreadsheets, these data analytics, these graphs, these programming forums and code repositories when you claim that you wish to pursue a career in medicine? The answer to this question comes through some of my life experiences. Throughout my life, I have spent countless months in hospital, clinical, and healthcare environments comforting loved ones through treatment processes for diseases like Parkinson's, leukemia, kidney failure, and Alzheimer's. Seeing what I have from these cases is the motivation that I have to implement these data analytics in my work, both now and in the future. Where did this obsession arise from? It came from dealing with the uncertainty of waiting weeks for countless lab examinations, test results, doctor's appointments, and all forms of medical diagnostics to be taken, interpreted, analyzed, and then communicated back to these patients through hurried voices by physicians who were already too burned out to continue giving the treatment that they give every day. This brings us to a broader topic in the status quo of healthcare. Every day in healthcare facilities across the world, after weeks of these tests and examinations, physicians sit down with their patients to finally debrief about their findings. Often, patients come to these conversations with their lives, their health, and the emotional health of their families at stake, only to be met with physicians who are dealing with workloads too massive for them to answer the infinite questions that follow. In fact, a study done by the Morning Consult just last year, a poll of 1,000 US healthcare workers on the adverse effects of healthcare shortages found that nearly 4 in 5 physicians claimed that this healthcare shortage had been a significant impact to their work and their ability to perform at the level they need. An insurmountable workload that has caused physicians to become completely burned out, says the author of the study. Healthcare infrastructures such as these, completely marred by bureaucracy, oftentimes do not have what it takes to provide the precision treatment, the personalized care that modern medicine should strive to be. These healthcare infrastructures often do not look at patients' unique physiologies, their backgrounds, their genomic profiles, their proteomic profiles, in-depth analysis of imaging in determining courses of treatment. The current medical literature analyzing cancer, for example, has begun to realize that many of these cancers that we deal with are not single diseases, but rather arrays of hundreds of genetic disorders that all impact how the true cancer will play out for every patient that develops it. These physiologies need to stop being treated as single diseases that all demand the same treatment. And rather, perhaps, this data should be included. For example, kidney cancer, as you can see on the screen above me, is made up of nearly 20,000 genes that are altered with over 30,000 mutations for these patients. And yet, genes like SETD2, which was not even analyzed in clinical prognoses for clear cell renal cell carcinomas until around 10 years ago, seems to be significant enough to cause a nearly 50% decrease in patient survival over the span of 3 years. Lack of resources and time is no excuse. Minute abnormalities in patients' physiologies deserve to be taken into account when determining their treatment plans. I wanted to do something about this. Inspired by the story of one of my good friend's aunts, and also by the nearly 13,000 people per year like her that died due to kidney cancers worldwide, I took a data set of nearly 340 patients with over 60 clinical variables, 30,000 mutations, and 20,000 genes analyzed along with proteomic profiles, and wanted to find a way to consolidate all of this information into something that may be capable of answering how kidney cancer would develop. Taking these millions of data points, I would develop a neural network which would take all of these inputs, use millions of nodes, procedurally generated, all with their own unique biases, all with their unique logic, in order to come to a consensus on an outcome as to when these patients' diseases would develop. The resulting algorithm was able to have 95% accuracy, determining patients' kidney cancer prognosis, the kidney cancer metastasis, and even development of cancers outside the original zone, up to 4 years in advance. Tools like this could be implemented in numerous diseases and could hold potentially the ability to allow our physicians, to equip our physicians with what they need to personalize treatment in the future. In a similar vein, neurodegenerative disease. Once I began looking into the true effects of neurodegenerative disease on American healthcare and the patients that develop it, I came to see things that severely worried me. For example, looking at multiple sclerosis, a demyelinating neurodegenerative disease, I saw that nearly 20% of patients diagnosed at UCLA and Cedars-Sinai, two of arguably the leading medical institutions of the United States in the past decade, were indeed misdiagnosed with multiple sclerosis. Analysis and quantification of cerebral structures using MRI has been known for years to hold significant value in prognosing and diagnosing these diseases, and yet whole brain quantification is something that remains a dream for clinical practice. Although radiologists are able to gain qualitative, subjective findings from their analysis of these scans, quantification, seeing just how much tissue is truly present in every single patient that takes a scan, is something that is excessively important and excessively powerful in treatment plans, and yet rarely does it ever happen in clinical implementation. For the past 3 years, I've been working to see how we can implement machine learning technologies to somehow make this quantification process, this neurodegenerative disease diagnosis process, more streamlined, more efficient, and more equitable, so that a patient living in a rural community in America can receive the same exact treatment that a patient would in a metropolitan city center in a university hospital, despite the need or availability of neuroradiologists. This result, an algorithm with 98% accuracy in classifying every form of tissue present in a patient scan. So why does it matter? In the future, technologies like the hyperfine portable MRI machine could be loaded with software such as this to provide neurodegenerative disease diagnostics in communities in which we have never seen them before. Places across the world, regardless of availability of medical centers, MRI machines, or neuroradiologists to analyze scans, could finally gain the capacity to diagnose patients' disorders and to also gain deep insights on how they may be fixed due to patients' unique structural profiles. Crumbling healthcare infrastructures, marred by bureaucracy, must begin to address these issues as the world moves toward a more personalized and modernized medical system that claims that unique patient attributes are taken into account. Perhaps technologies such as these could be the leading factor in determining whether or not we will be able to make sure these advances are equitable or not. Every patient that needs care should get it, regardless of availability of resources. In a similar vein to how agriculture was revolutionized through technology, exponentially increasing our capacity to provide for 8 billion people in the world today, with exponentially fewer people actually involved in the process of agriculture. Perhaps machine learning could do the same for medicine, allowing us to fill the demand gap in healthcare. This study, done even prior to the COVID-19 pandemic by the American Association of Medical Colleges, shows that regardless of however we approach it, healthcare demand will always stay ahead of healthcare supply. Regardless of how many neuroradiologists are pumped out by our university hospitals or residency training programs, we will always see this gap in healthcare up to 10 to 20 years in advance. So, my message to the Augusta community and global community today is to adapt, unite, and grow to secure the future of healthcare. We must adapt our healthcare infrastructures to implement these technologies as soon as possible. Every day that these patients are left without the treatment options that are available to patients outside of the rural communities which lack these resources, we lose people. We are losing patients who deserve the treatment that could be provided to them through these technologies. We need to unite in our call for healthcare equity so that every patient across the world could receive this form of care. And we need to grow our capacities to recognize patients' unique genomic, proteomic,